Right. Good morning, everybody. On behalf of the Ceylon College of Physicians, let me welcome you to the Young Physicians Forum for the month of May. This time, in view of the COVID-19 situation, this is a webinar entirely streamed online. However, the presenters are here with us today. And we have two speakers, both senior registrars. The first talk is by Dr. R.C. Rajiv Kumar, who is a senior registrar in nephrology at the National Hospital of Sri Lanka, who is going to speak on anemia in chronic kidney disease. And then following that, we have Dr. Chaturika Kempitia, who is a senior registrar in cardiology at the National Hospital Colombo, who is going to speak on MINOCA and INOCA, what, who, why, and how. The session is sponsored by CIPLA today. May I invite Dr. Rajiv Kumar to deliver the first talk on anemia in chronic diseases, chronic kidney disease.
Good morning, everyone. Thank you, sir, for that kind introduction. And thank you. I'm thankful for the College of Physicians for giving me this opportunity. So my talk will be on anemia in chronic kidney disease. Anemia is one of the frequent complications that we see in chronic kidney disease patients. And it becomes more apparent as the GFR declines below 60. And the prevalence is more in patients who are on maintenance hemodialysis. And it increases the mortality and hospitalizations. And the causes for anemia are diverse and complex. So it could be, it's multifactorial, starting from nutritional deficiency, then drug-related, mineral-borne disease, bone marrow suppression due to uremia, other comorbidities, and short red cell lifespan. However, the most important causes are highlighted here, such as inflammation, infection, which results in functional iron deficiency and poor erythropoietin response on bone marrow, as well as there is reduced erythropoietin production, and there is also absolute iron deficiency, mainly contributed by malnutrition and poor absorption. Also, in patients who are on hemodialysis, there is blood loss as well. So the mentioned causes can be, some of them are correctable and some of them are not correctable. So it's very important to identify the correctable factors and treat them. So this is the diagrammatic representation of how anemia in chronic disease evolves. As we know that inflammation is the main factor which results in increased hepcidin levels, which is also contributed by poor renal clearance. And hepcidin it reduces the absorption from the iron absorption from the gut, as well as the release of iron from the macrophage as well. And also there is reduced erythropoietin production, and due to uremia, the action by the erythropoietin on bone marrow is also affected. Also, there is reduced red cell lifespan, as well as there is blood loss in hemodialysis patients. All these contribute to anemia in CKD. As in general population, the diagnosis is arrived from the same cutoffs, like the hemoglobin below 13 in males and less than 12 in females, as defined as anemia. And in patients who are end stage and who are on dialysis, the hemoglobin levels tend to fall up to 8, or even it can go up to 6, even in the absence of any obvious bleeding or hemolysis. But in non-dialysis patients, having low level of hemoglobin should be evaluated. And it is always important to evaluate for a potential cause. When it comes to evaluation of anemia and their frequency, it depends whether the patient is anemic or not anemic, and also whether the patient is on dialysis or not on dialysis. Patients who are on dialysis, irrespective of their state of anemia, they have to be evaluated every 3 months with full blood count and iron studies. However, on non-dialysis patients, if they are with non-anemic, then they could be evaluated either annually or biannually, whereas if they are anemic, then more frequent evaluation is needed. As in general population, the anemia of evaluation of anemia starts with full blood count, blood picture, and nutritional factors, as well as in case we need to do the stool for blood as well. It is important to highlight that we do not routinely measure erythropoietin levels. Management of anemia is multimodal, and I will be discussing them in detail. The most important thing to highlight is the iron deficiency. It could be either absolute or functional. And absolute iron deficiency is defined as diminished or absent bone marrow iron stores, which a diagnosis by bone marrow biopsy, which is technically challenging. So we use that surrogate of iron studies to diagnose them. So it is diagnosed as when transferrin saturation is below 20 and serum ferritin levels in non-dialysis patients less than 100 and dialysis patients less than 200. And what is functional iron deficiency? It is where when the transferrin saturation is less than 20 with normal or even elevated ferritin levels. This can be due to two major reasons. Either it is due to erythropoietin therapy, ESA therapy, or anemia of chronic disease. And the differentiation depends on the response to IV iron therapy with concomitant administration of erythropoietin stimulating agents. If it is due to ESA therapy, the anemia should improve, whereas on the latter, it will not improve. And absolute iron deficiency is one of the marker of cardiovascular risk, and it increases the hospitalization as well. So when it comes to iron therapy, again it depends on whether the patient is anemic, whether the patient has got patient is on not on dialysis, or whether the patient is on dialysis. Patients who are non-dialyzed, irrespective of the state of any hemoglobin, if their transferrin saturation is less than 20 or ferritin less than 100, they should be treated with iron. But in patients who are anemic, and if their transferrin saturation is less than 30 or ferritin less than 500, need treatment. However, if their transferrin saturation is more than 30 or 50, do not require iron replacement. On the other hand, when it comes to patients who are on hemodialysis, again same as non-dialysis, irrespective of their hemoglobin level, if their transferrin saturation is less than 20 and ferritin less than 200, needs iron replacement. Ideally, it is IV iron therapy. And if the patient is anemic, particularly when the HB is less than 10, and even if the transferrin saturation is less than 30 or ferritin less than 500, again needs treatment. And it is important in patients who are on hemodialysis, we also need to keep them on maintenance iron therapy for those patients who are on erythropoietin stimulating agents. In patients who are on hemodialysis, if the targets are not achieved, we may have to repeat the doses until we reach the transferrin saturation more than 20. And if they are still not responding, it is important that we rule out other causes, especially bleeding. And it is important that administration of iron will restore adequate iron store, and it will increase the hemoglobin level, so that even in the absence of erythropoietin stimulating agent therapy. And there are a lot of evidence for iron therapy, and in fact it has shown that it reduces the need for starting erythropoietin stimulating agents, and it is called the iron first approach. And also it is important to remember that some of the sub-analyses which were done primarily for heart failure studies like FAIR-HF, which has shown that there has been improvement in the renal function in patients who were treated with IV iron therapy. So whether to give oral or iron, there are several guidelines. They suggest give different opinions. However, we mainly go by the KDIGO guideline, which recommends oral iron therapy or intravenous iron therapy for those patients who are on non-hemodialysis, whereas if the patient is on hemodialysis, IV therapy is preferred. Apart from that, the other indications for parenteral iron would be when the patient has severe iron deficiency or severe anemia, or when there is ongoing blood loss. And if the patient has intolerance to oral iron therapy, again we could consider IV iron. When it comes to oral iron, the daily requirement of elemental iron is around 200 milligram per day, and the commonly administered drug is ferrous sulfate, which has an elemental iron of 65 milligram. So it is important to treat the patients at least one tablet 3 times a day to achieve the targets. And also there are other preparations are also available. The important one to remember is the ferric citrate and sucroferric hydroxide, which has a phosphate binding capacity as well. So it is very important. It is important that patients who have got hyperphosphatemia and mineral bone disease, these are preferable. When it comes to intravenous iron therapy, again there are different formulations are available. The one that is commonly used is iron sucrose, and it has its own adverse side effects profile, namely allergy and anaphylaxis, especially with dextran-based iron therapy. Even though the ones that are commonly used are non-dextran, still they also have like about 0.5% risk of anaphylaxis. And it is important to monitor these patients even after the infusion is over. And also it is important to remember that there is increased risk of bacterial infection, so that patients who have active infection, we should avoid giving IV iron therapy. Also there are minor side effects like transient tubulopathy and hepatic overload, iron overload also have been reported. So when it comes to IV iron therapy, the recommended dose is 1000 milligram of elemental iron, 1000 milligram, and it can be given in divided doses. So that will be able to achieve the hemoglobin level from 8 to, it will increase from 8 to around 11 to 12 with concomitant initiation of ESA therapy. And if the patient is on erythropoietin stimulating agents, then we should put them on a maintenance iron for about 250 to 500 milligram once in 3 months to maintain the iron stores. There are several landmark trials. One of the important trial is the pivotal trial, which has the study was to compare high dose IV iron therapy versus low dose regime, where in the high dose the targets were to achieve transferrin saturation levels of more than 40 and ferritin more than 700, and low dose where it is just to maintain above 20 transferrin saturation and more than 200 and dialyzed patients. And the study showed that there was no increase in the death or any cardiovascular events, and it has, the higher dose has shown to achieve the hemoglobin targets earlier, and there was less need for ESA and blood transfusion. And it is important to monitor the patients once iron therapy is started. If the patient is on oral iron, then at least 3 monthly we need to monitor, and if the patient is on IV therapy, then once the course is completed, after 1 month we could repeat the iron studies and see the response. Once the correctable causes are identified and treated, then next thing is to move on to the erythropoietin stimulating agents. And we should always balance the benefit and risk. And it has shown that ESAs reduce the need for transfusion, improve quality of life, exercise tolerance, left ventricular hypertrophy, and also it has been shown to reduce mortality. And it also has its own side effects. There are like increased cardiovascular events, increased risk of malignancy and thrombotic events, and hypertension as well. It is important to note that malignancy and the thrombotic risk are high when the targets of hemoglobin targets are higher, whereas the hypertension can occur even in normal hemoglobin targets, and seizures are also have been reported. So when to start erythropoietin stimulating agent? So in CKD patients, the target, the cutoff is 10. So when the hemoglobin is less than 10, and in the transferrin saturation is more than 25 and ferritin is above 200, so that is we have treated the iron deficiency, so then we could start the patient on erythropoietin stimulating agent. However, the targets are individualized. For example, in young patients who have risk of bleeding, who needs higher targets, we could even start even at a higher level of hemoglobin levels. And there are different preparations are available. The one that is commonly available is the short-acting one, the epopoietin alpha, and also there are long-acting preparations are also available. But there are no head-to-head trial between these two to show the superiority of formulations and different administration one over the other. The dosage is depend on the weight, and it's the epopoietin alpha, the short-acting one. We start with 50 to 100 units per kg per week, and it can be given either once a week or once in 2 weeks. They are administered subcutaneously. So the dose will come about 4,000 to 10,000 weekly, or once in 2 weeks 10,000 to 20,000. And so the frequent administration, the less frequent or weekly administration is seemed to be effective and safe than frequent administration. And we should always give the lowest possible dose and should not increase the frequency without assessing and correcting other the factors. And our target should be to achieve 11.5 hemoglobin. And if it goes beyond that, we should reduce the dose by 25%. And the route of administration of ESAs depends on patient is whether on dialysis or non-dialysis. So dialysis patients, we can give both intravenous and subcutaneous, whereas non-dialysis patients, it is well administered as subcutaneous. And in fact, subcutaneous dose has shown that there is requirement for the requirement is 30% less than the intravenous route, as well as it preserves the vein as well. So our targets is to, as I mentioned earlier, to achieve the hemoglobin to a level around 11.5. And it again is it is individualized. So some patients with high bleeding risk and who has risk of blood transfusion and complications related to that, we could target even a higher hemoglobin, but never more than 13. So there are different trials where low targets versus high targets have been assessed. NHCT, QUARK, CREATE and TREAT. And in these trials, it has shown that the targets, when they are targeting for a higher hemoglobin, there is increased risk of cardiovascular events. So it is not recommended. And so all these patients, when they are started on erythropoietin stimulating agent, we should monitor their hemoglobin and iron levels. So in non-dialysis patients, hemoglobin should be assessed every 2 to 4 weeks, and then once the target is achieved, then every 3 months. And patients on dialysis, once a month we should assess their hemoglobin. Again, the iron studies also should be repeated every 3 months while the patient is on erythropoietin stimulating agent therapy. And another important entity that we should know is the ESA hyporesponsiveness. It is defined as inability to achieve or maintain a desired hemoglobin concentration using a maximum dose of 450 units per kg via intravenously or 300 units per kg per week subcutaneously, or whether there is an increased requirement for ESA dose by 50% beyond the dose at which it was initiated. So this is one of the predictor of cardiovascular risk, and it should be addressed. And we should never, we should avoid repeated escalations without assessing the underlying cause. So we need to evaluate when there is ESA hyperresponsiveness. It's important to rule out poor adherence. And we need to see whether there are any other factors like the nutritional deficiency and other factors that I mentioned. And also, sometimes you may have to go with the bone marrow biopsy as well. Once all these have failed to achieve our targets, then the next option is to go for blood transfusion. So there are no threshold for us to decide when to start on hemoglobin. So it mainly we go by the symptoms and signs. So we always need to balance the risk and the benefit, and whether the acute drop in the hemoglobin or whether it's a chronic anemia. So in acute situation, as in general population, when a patient comes with severe hemorrhage, or when the patient comes with a coronary artery disease, or there is a requirement for rapid HB correction, then of course we need to transfuse blood. In that instance, our HB should be at least to achieve above 7. But in chronic conditions like when there is hemoglobinopathies, or when there is bone marrow failure, or there is no response, poor response, or resistant or contraindication to ESA, again we may have to go ahead with the transfusion. So transfusion has its own risk. As we know that in CKD patients, they are at risk of volume overload and also risk of hyperkalemia. And the other important thing is patients who are awaiting transplant, they are at risk of alloimmunization. So we should avoid transfusion. And another important thing which is emerging is the novel therapy, which are now promising. It is called the hypoxia-inducible factor prolyl hydroxylase inhibitor, HIF-PHIs. And one of the well-known and studied drug is the roxadustat, which has now been approved in China and Japan for usage. So the mechanism of action of HIF-PHIs are that it stimulates the transcription of erythropoietin gene so that it increases the endogenous erythropoietin secretion. And it also has its own pleiotropic effects, such as it improves the iron utilization and bioavailability. Also, it reduces the LDL levels, and it has protection against the cardiovascular risk, and it protects and reduces the progression of CKD, and it improves the blood pressure control as well. So there are studies for patients who are on hemodialysis as well as non-dialysis patients. In non-dialysis patients, again, it was studied with epopoietin alpha. It has shown that it is superior to erythropoietin in anemia correction. And the cardiovascular risk, the major adverse cardiovascular events was equal as epopoietin. And it has reduced need for iron replacement as well. And on the other hand, in non-dialysis patient, again, compared to placebo, and also there was study against darbepoetin, it has shown that it is efficacious, and the cardiovascular events, in fact, it is equal as the other therapy. So there are concerns with regard to HIF-PHIs, like there is a concern whether it could increase the risk of cancer, thrombosis, and growth of renal cyst, and worsening of diabetic retinopathy and pulmonary artery pressure. So in summary, my take-home message is CKD in anemia is multifactorial, and the approach should balance the risk versus benefit. When we are evaluating the patients and managing the patient, it is important to rule out the treatable conditions. And first, the most important thing is to correct the iron deficiency, because that would reduce the need for other therapies. And when the patient is on erythropoietin stimulating agent, we should target for a hemoglobin within 10 to 11.5, not beyond that. And HIF-PHIs are promising, and they require further studies. Thank you, everyone.
Thank you very much, Dr. Rajiv Kumar. We can have a few questions. I haven't got any questions online, but the audience is invited to type their questions into Zoom if they have any questions.
In other conditions, we generally discourage the use of IV iron. But there is a particular place here in CKD. What's the difference there?
There are many reasons, madam. One is that in CKD patients, especially patients on hemodialysis, their absorption rate of oral iron is very much less. And as I told, there is a functional iron deficiency as well. So because of that reason, parenteral iron has shown to be more effective, and because it increases the absorption and the and also it's mainly because of the increased absorption, the effect. And also it has the studies also, like the one that I mentioned, the heart failure studies also have shown it's with IV therapy, which has shown to be superior. They have not tried with oral iron.
So why is the absorption less in CKD?
Sorry, sir?
Why is the absorption less? What's the reason? What's the mechanism that's postulated?
There are many reasons, especially because these patients have gut edema, and that will reduce the absorption of, and their appetite also poor, so anyway their intake is also reduced.
We haven't had any questions online. Anything else from the audience? So in the absence of further questions, thank you very much, Dr. Rajiv Kumar. You have a certificate from you. We shall move on with the session, and the next talk is by Dr. Chaturika Kempiti, who is a senior registrar in cardiology, who is going to speak on MINOCA and INOCA, what, who, why and how. Thank you. Over to you.
Thank you, sir. And good afternoon, everybody. I am Dr. Chaturika, Senior Registrar Cardiology. Today, my topic is MINOCA and INOCA, what, who, why and how. So, MINOCA stands for myocardial infarction with non-obstructive coronary arteries, and INOCA stands for ischemia with non-obstructive coronary arteries. So, within next 20 minutes, I will be talking about what is MINOCA, who is more prone to get MINOCA, why it is important to diagnose MINOCA, how MINOCA should be investigated, and how MINOCA should be treated. And then I am going to repeat the same W and H questions for INOCA as well in a summarized manner. So before going into my presentation, I would like to present you a patient who's a 40-year-old previously healthy female, mother of 3-month-old baby, presented to us with typical ischemic type chest pain. ECG showed anterior ST elevations and thrombi was elevated, and 2D echo showed elevated territory ischemia. We rushed her to the cath lab and did the coronary angiogram. But it was normal. But we didn't stop at that. We put a tiny ultrasound probe into the epicardial artery, and that has showed something like this. There is a separation of adventitia and media of the coronary artery. There's a dissection which has got intramural hematoma. This condition is called spontaneous coronary artery dissection. So, is this MINOCA? We'll move on to the definition of MINOCA. The conditions comes under MINOCA should have acute myocardial infarction definition according to the 4th universal criteria of MI, and non-obstructive coronary arteries on angiography. That means less than 50% stenosis in angiogram. And they shouldn't have any alternative diagnosis as well. So this is the criteria for MINOCA. So our first case, the patient has had acute myocardial infarction according to the 4th universal definition, non-obstructive coronary arteries on the angio, and no alternative diagnosis as well. So this is MINOCA. So I'll present you another case, 50-year-old woman presented to us with severe chest pain during the son's funeral, and anterior ST segment elevations are there, thrombi was high, and 2D echo showed apical hyperkinesia. We did the coronary angiogram. Again, it was normal, but we didn't stop at that. We did the left ventriculogram, which has showed apical ballooning. And can this be MINOCA? So, second case, there's acute myocardial infarction according to the 4th universal criteria of myocardial infarction, and non-obstructive coronary arteries on angio. But there is an alternative diagnosis. This is Takotsubo cardiomyopathy. So, Takotsubo cardiomyopathy and myocarditis not included in the recent definition of MINOCA. This can clinically mimic MINOCA, but they are distinctly different syndromes. So, they should be separated. They should be considered separately. So, Takotsubo and myocarditis out. But what are the conditions comes under MINOCA? Heterogeneous conditions grouped under this umbrella term. There could be atherosclerotic causes like plaque disruption, which we can't pick up in the angiogram. And there are non-atherosclerotic causes. Main causes are the vasospasms in the large arteries, coronary embolism and thrombosis, which we can't pick up again in the angio, and spontaneous coronary artery dissection and microvascular dysfunctions. So, we'll go one by one about these causes. What is plaque disruption? This is actually cause 1/3 of MINOCA. Plaque rupture, plaque erosions and calcific nodules, which we can't pick up in the angio, comes under this condition. This can cause MINOCA by thrombus formation and can cause myocardial infarction. by distal embolization, superimposed coronary spasm, and transient complete thrombosis with spontaneous thrombolysis. So we can't detect this in the angio. But usually they have minor atherosclerosis somewhere in the angiogram. The angiograms are not completely normal. There's minor atherosclerosis somewhere in the angiogram. So that is the first cause for MINOCA, plaque disruption. The second one is large coronary artery vasospasm. Around 46% of patients with MINOCA have vasospasms. Intense vasoconstriction, more than 90% vasoconstriction, can compromise myocardial blood flow, and prolonged episodes can cause MI as well. They present with rest angina with dynamic ST segment elevations in ECG. And the cause for the vasospasms is coronary vasomotor tone dysfunction. Vascular smooth muscle hyperactivity is the main cause, and inflammatory mechanism also plays a role. Drugs and toxins like cocaine, fluorouracil can cause vasospasm, and it can occur spontaneously as well. So third important cause for myocardial infarction with non-obstructive coronary artery disease is spontaneous coronary artery dissection. There's a separation of media and adventitia. There's a dissection of coronary arteries, and the intramural hematoma protrude into the lumen and cause the obstruction. Usually these patients having underlying vasculopathy, and there can be a precipitating stressor like emotional stress, like extreme physical activities. After these stresses, this patient can come with typical ischemic chest pain. And this spontaneous coronary artery disease can be associated with vascular diseases such as fibromuscular dysplasia, and it can be associated with pregnancy as well. So our first patient is a postpartum patient presented with spontaneous coronary artery disease. The next important cause for MINOCA is coronary emboli and thrombi. It can cause MINOCA if it involves the small arteries, which we can't pick up in the angio, or if partial lysis of the epicardial large artery coronary thrombus occur, then it can cause myocardial infarction with non-obstructive coronary artery disease. And this can occur with cardiac interventions as well. So the next important cause for MINOCA is microvascular dysfunction. This is an unknown entity for a long time, and this was initially named as syndrome X as well. So what is coronary microcirculation? The tiny arteries diameter less than 1 centimeter comes under microcirculation. It's not easily visualized, and it's a challenge to assess these arteries as well. But it accounts for 70% of coronary resistance. So this large coronary arteries, our right coronary, our left coronary, we all know, but there's a large, complex, tiny artery system beneath that, which we can't usually not visualized, which is very challenging to assess, but it can go wrong structurally, functionally, and cause microvascular dysfunction. So this is another picture of these tiny arterial complexes, the microvascular system of the heart, which can go wrong and cause diseases, which was an unknown entity for a long time, but now there are objective ways to assess. So this is another picture. This is a cross-section of the heart showing the tiny arteries going and supplying the myocardium, and this sub-epicardial portion of the myocardium, which is more away from the large arteries, is more prone to get ischemia. So this microvascular dysfunction can be in two ways. The tiny arteries can structurally go wrong, which can cause structural remodeling, and they can go functionally wrong as well because of the vasomotor disorders. This entity largely contributed to the stable angina, ischemia with non-obstructive coronary artery disease. However, in extreme situations, it can cause myocardial infarction as well. But because of the myocardial injury due to a ischemic or non-ischemic cause, in turn can cause microvascular dysfunction as well. So in MINOCA, there is a dilemma. Is it a cause for acute myocardial infarction, or is it a consequence of it? So now we have covered the main causes for myocardial infarction with non-obstructive coronary artery disease. So who is more prone to get MINOCA? It's younger female. The average age is 58. 58 is not younger, but compared to the obstructive coronary artery disease, this is a younger age. And 50% of myocardial infarction with non-obstructive coronary artery patients are women. And if woman gets a MI, chance to be MINOCA is twice as high as a man. So why common in women? Because the female coronary arteries are different to male coronary arteries. They are small diameter. The atherosclerosis is diffuse. By the men, they are having focal atherosclerosis and they are having less calcification, more soft plaques. So we can't pick up the plaque ruptures during the coronary angio. And they are more prone to get vasomotor dysfunction. And they are more prone to get epicardial and microvascular spasm. Estrogen fluctuations plays role in vasomotor dysfunction. So, then why it is important to diagnose MINOCA? No obstruction shouldn't mean no diagnosis. MINOCA accounts for 8 to 14% significant percentage of acute myocardial infarction. And the treatment is cause targeted mostly. For the spontaneous coronary artery dissection, as example, we do not start statins and we do not stent as well because there is a chance of spontaneous healing. And vasospasms, we usually do not give beta blockers. And for the microvascular disease, usually for the vasospastic anginas, calcium channel blockers helps. So treatment is different. So diagnosis is important. Is MINOCA bad? Not as obstructive coronary artery disease, better prognosis compared to patients with obstructive coronary artery disease, but lower survival rate than healthy individual. It's not completely benign. So how do you evaluate MINOCA? So there's a traffic light sequence to evaluate MINOCA. First, we have to keep the MINOCA as a working diagnosis at the time of the coronary angiogram with non-obstruction. And we have to exclude the other causes for thrombi rise, such as pulmonary embolism, sepsis. And then we have to exclude the overlooked diagnosis. We have to reassess the angios. We have to look for the missed obstruction. We have to look for the myocardial injuries, which can closely mimic myocardial infarction. Then once we diagnose MINOCA, then we have to look for the cause. We have to look closely at the large arteries, and then we have to look at the microvasculature as well, and then we have to look for the vasospasms. And thrombophilia screening also plays a role. So this is the traffic light sequence of evaluating MINOCA. We have to stop and we have to think about the other causes, the alternative diagnosis for elevated thrombi. Then we have to look for the missed obstruction or myocardial injuries. And then when we diagnose MINOCA, we have to look at the large arteries, small arteries, vasospasms, and we can do the thrombophilia screen. So during this process, the cardiac MRI helps a lot. In studies have showed around 87 of patients with MINOCA, underlying cause is identified with cardiac MRI. The late gadolinium enhancement pattern helps here because in the ischemia, the subendocardial portion is more prone to get ischemic, and late gadolinium enhancement in myocardial, the cardiac MRI occur in the subendocardial portion in ischemic causes. However, in cardiomyopathies and myocarditis, the late gadolinium enhancement occur in subepicardial portion. So this is a picture of various cardiac MRIs, which is showing the late gadolinium enhancement pattern. In the ischemic cardiomyopathy, there's a subendocardial portion late gadolinium enhancement, and in other causes, there are different patterns. This is again a graphical representation of late gadolinium enhancement of cardiac MRI. So with cardiac MRI, we can differentiate non-ischemic causes which can closely mimic MINOCA from ischemic causes. So then we have to look closely at the large coronary arteries. IVUS and OCT helps in here. for the detection of unrecognized causes of coronary angiography, especially thrombosis, plaque ruptures, or spontaneous coronary artery dissections we can detect by here. In the IVUS, we put a tiny ultrasound probe to the coronary artery disease and we can get the 2D images like this. And in the ultrasound, we put sound waves. If we put an infrared wave to the coronary arteries, then we can get a high resolution image like this. This is OCT, optical coherent tomography, which can pick the missed plaques, thrombosis, spontaneous coronary artery diseases in the large coronaries, which can account for MINOCA. So, recently published HARP MINOCA study has showed around 85% of patients with MINOCA cause should be identified with the OCT and cardiac MR. And if we suspect coronary thrombosis or emboli, thrombophilia screening also helps. And then we can look for the vasospasms. We can inject intracoronary acetylcholine and see with the intracoronary acetylcholine, if there are large coronary artery spasm, angiogram looks like this with ECG changes and symptoms. If the angiogram is normal with the intracoronary acetylcholine and still the patient is getting symptoms and ECG changes, then we can suspect microvascular spasms. So that is how we evaluate vasospasms. Then we can assess the tiny arteries of the heart as well. There are objective ways to assess tiny arteries now. There are non-invasive ways as well as invasive ways. This is a picture of functional cardiac MR, which helps to assess the microvasculature, and we can put a guide wire to the large coronary arteries and we can objectively assess the microvasculature as well, the resistance of the microvasculature and the ability of the microvasculature to dilate in hyperemia. So there are objective ways now to assess the microvasculature. So how do you treat MINOCA? So we have to give the emergency supportive care as other MIs, and we have to keep a working diagnosis approach for patient evaluation. Then we have to give the cause targeted therapies. So for the plaque disruption, we can treat as obstructive coronary artery disease as well. But for the epicardial vasospasms, we have to give calcium channel blockers. Usually a very high dose, around 240 milligram BD dose of diltiazem sometimes needs for treating vasospasm. And for the coronary embolism or thrombosis, we can give anticoagulation. And for the spontaneous coronary artery disease, usually we do not start statin. Usually it has ability to heal spontaneously. And if it is not, then we can try stenting. And microvascular dysfunction management, I will deal with the INOCA. So, no obstruction shouldn't mean no diagnosis, but could all MINOCA patients get a definite diagnosis? Around 8 to 25% of patients, despite optimal workup, cause of MINOCA remains undetermined. This entity is categorized as MINOCA of unknown cause. So, this entity we can follow up as acute coronary syndrome with obstructive coronary artery disease, and we can treat for the most probable causes of MINOCA. Those are vasospastic angina, coronary plaque disruption, or thromboembolism. But for the evidence for the dual antiplatelet is less. However, aspirin, statin, AC inhibitors and has showed a benefit in treating MINOCA of unknown cause. And if we suspect vasospasms, calcium channel blockers also we could try. So now we have covered what is MINOCA, who is more prone to get MINOCA, why it is important to diagnose MINOCA, how MINOCA should be investigated, and how MINOCA should be treated. Before going into INOCA, I'll present you another case. This is a 50-year-old female presented with class 2 angina, exercise ECG stage 3 positive, and repeatedly normal coronary angiogram. But patients coming repeatedly with the symptoms, and psychiatric referral also has been done. So, what is this condition? Is this INOCA? So, INOCA stands for ischemia with non-obstructive coronary arteries. up to 70% undergoing coronary angiogram because of angina with demonstrable myocardial ischemia, have no obstructive coronary arteries. So our patient also has a demonstrable myocardial ischemia. Her exercise ECG is positive and she hasn't had any obstructive coronary artery disease. So this entity is called INOCA. So the main two mechanisms accounts for INOCA are coronary vasospasms, which cause vasospastic angina. This clinical entity causes vasospastic angina, and coronary microvascular dysfunction. This clinical entity is called microvascular angina. So why it is important to diagnose INOCA? Because it's common. Because 70% of female and 30 to 50% of male undergoing coronary angios have demonstrable ischemia without obstructive coronary arteries. And it's not a benign condition. It can impair quality of life. It can lead to repeated hospitalization and unnecessary coronary angiography, increased healthcare costs, and increased incidence of cardiovascular events. And we can give tailored therapy. If we diagnose vasospastic angina, we can give calcium channel blockers. If we diagnose microvascular angina, beta blockers are first line. So we can give tailored therapy. So that's why it is important to diagnose INOCA. So who is more prone to get INOCA? Again, young women. Traditional risk factors, the role in INOCA is not well established. However, non-classical risk factors like estrogen fluctuation, inflammation, genetics, migraine, psychological aspects can play a role in INOCA. So how to investigate INOCA? So how to investigate those two main mechanisms, vasospasms and microvascular dysfunction. For the vasospasms, we can use intracoronary acetylcholine and assess for the large coronary artery vasospasm. If it is not there, we can identify microvascular vasospasm. And for the microvascular dysfunction, now there are objective ways to assess. So this is a graphical representation of assessing the INOCA and how to manage INOCA. So we have to initially we have to incorporate the lifestyle modification and risk factor management. And then if we diagnose vasospastic angina, the calcium channel blockers high dose is the first line. Then long-acting nitrates and nicorandil we can try. So if we diagnose microvascular angina, beta blockers, calcium channel blockers, beta blockers is first line, but we can try calcium channel blockers and nicorandil as well. Statin and AC inhibitors we can consider. There's a large randomized control trial going on, which is name is Warrior, but still the evidence is less for statins and AC. And low dose tricyclic antidepressants, imipramine also we can try. This is again a graphical representation of management of INOCA. If we can diagnose the subtype, we can tailor the therapy. So we have, in Sri Lankan context, do we have these hi-fi investigations? Yes, we have. We have cardiac MRI in some places. IVUS, FFR available. But vasospastic studies and OCT we are not doing. But we can try a therapeutic trial of calcium channel blockers if we highly suspect vasospastic angina. So take-home messages for MINOCA is 8 to 14% acute MI can cause by MINOCA. So no obstruction shouldn't mean no diagnosis. And there are heterogeneous causes which can cause MINOCA. If uncovered, cause-targeted therapy can be given. For take-home messages for INOCA, it's common, it's not benign, it's often misdiagnosed, and main mechanism is coronary vasospasms or microvascular dysfunction, and there are objective ways now to assess, and stratified personalized treatment we can give if we can assess the major two types. So that will be MINOCA and INOCA, and these are my references, and thank you very much.
Thank you very much, Chatrika. We can have some questions. I have a couple of questions from the audience. The first one is Coronary syndrome considered as MINOCA?
Yes, sir. In some reports, it can consider as MINOCA because in the Cooney's syndrome, because of the allergic reaction, intense vasospasms can occur. So, in some reports, it can cause it as considered as MINOCA, but not as a major cause. In this presentation, I tackle only the major causes.
I also had a question about your first case. You found that there was a dissection.
Yes, sir.
So wouldn't that count as obstructive?
Sir, that's a very valid question, sir. Thank you for that question. There are subtypes of spontaneous coronary artery dissection. If the hematoma is very large, it can cause obstruction and we can pick it up in the angio as well. But the type 2, which is diffuse, usually cause haziness in the angio. It can cause, the hematoma is there, but the hematoma is not large enough to cause the large occlusion. So usually that type we can't pick up in the angio. So the first type, it comes under obstructive coronary artery disease, but the second type, it comes under myocardial infarction with non-obstructive coronary artery disease.
So in this case, it was not visible on the angio?
No, sir.
Wouldn't it depend on the rotation, on the plane?
Yes, sir. Actually, that's true. That's why we have to look closely for the misdiagnosis, overlooked diagnosis. We have to go back to the angios. We have to review them and see whether we have missed any haziness, any tiny obstruction before diagnosis of MINOCA. But in this case, we couldn't pick up any.
Would manage them as an ST elevation myocardial infarction, a vast majority of them. And a vast majority of them would actually not get an angio either. Still, it's a situation here. But when you went through the management, there are some drugs that we would normally use which are contraindicated in these people, which you wouldn't give. So my question is, how would you suspect that this is a MINOCA in a normal person that you would see in the wards?
Yes, yes, madam. Thank you for that question. With the history, if the patient is not having any traditional risk factors, we can suspect. As an example, this patient with spontaneous coronary artery dissection hasn't had any coronary risk factors. She's a young female postpartum. That's why we didn't stop at angio. We went ahead with IVUS. So, with the history, we can suspect. Then vasospastic angina, again history helps. They occur in rest and with ST elevation. So if we highly suspect vasospastic angina, we can avoid beta blockers. In emergency situations, we can try calcium channel blockers if the arrhythmias are continuing with the MI as well. So that's how we have to tackle, madam.
I have one more question from the audience. How does TCA help INOCA?
Sorry, sir.
How does TCA help INOCA?
Thank you, sir, for that question. In INOCA, there is a psychological aspect which can cause the pathophysiology of INOCA. So it's not well established. The mechanism is not well known, but the studies have shown the lower dose imipramine can help in INOCA. So there's no overt psychiatric diagnosis, but low dose imipramine can help for the psychological aspects which can cause the pathophysiology of INOCA, which is not very known up to now, sir.
So is it possible that it's similar to something like IBS, where it has a modulatory effect on the nerves or the membranes, the neural membranes, and whether that's the effect? I'm just asking. Do you know anything?
It's not known yet. I'm not very sure, sir.
Because it could be the psychological effect, or it could also be some kind of neuromodulatory effect.
Neuromodulatory effect as well.
Yes.
I'm not very sure.
I didn't ask this question. Somebody in the audience. There's another question. Is nifedipine a better choice than diltiazem for coronary spasm?
Usually, diltiazem we use or verapamil. But not very sure which is more beneficial, but usually what we use is verapamil or diltiazem, and we have to give very large doses for coronary.
So I think the question was about nifedipine. Perhaps it's the fact that nifedipine can cause a tachycardia or accelerate the heartbeat that is a reason why it's not given.
Yes, in the acute coronary event, usually nifedipine we do not use.
You can combine it with a beta blocker in normal circumstances, but you'll be hesitant
to... But the vasospasms, beta blockers
so
are not very good.
I think that would be the answer, that since you can't combine it with a beta blocker, you wouldn't use a drug which accelerates the heart rate. Any other questions? Okay, that was a very interesting presentation. I learned something quite new. I didn't know what MINOCA and INOCA were in the past, so we live and learn. In the absence of further questions, I would like to thank you, Chaturika, for your excellent presentation, and nothing further. Thank you very much. And there's a small certificate. That brings us to the end of the Young Physicians Forum. We had two excellent talks by Dr. Rajiv Kumar on anemia and chronic kidney disease, and MINOCA and INOCA, what, who, why and how by Chaturika Kempitiya. Thank you very much to both of the speakers and to the judges, Professor Chandani Vanigatunga and Dr. Upul Disanayaka, for spending their time. I'd like to thank the audiovisual crew and the staff of ClinMark. In the difficult times, difficult to organize things like this, and to CIPLA for their sponsorship, and to Dr. Priyamali Jayasekara, who is the organizer of this series. Thank you very much, and that brings us to the close of this session. It will be followed by the college lecture, but I think we have a short break in between. Thank you very much.